myself, Dr. Pankaj Singh, working as Assistant Professor of Cardiology in UNMICR. Today I'm here to discuss with you hypertrophic cardiomyopathy. We will discuss this topic under the following headings. So first, SCM is a genetic disease state characterized by non-explained left ventricular hypertrophy associated with non-dilated ventricular chambers in the absence of another cardiac or systemic disease that itself would be capable of producing the magnitude of hypertrophy evident in given patient. Its prevalence is estimated to be 1 in 500 patients. Idiopathic hypertrophic subaortic stenosis, hypertrophic obstructive cardiomyopathy, and MMSS are older terms. Like beta MS myosin heavy chain mutations, clinical presentation apparently by late adolescence and develop substantial hypertrophy and more severe diseases. The mutations of myosin binding protein chain mutations have delayed clinical presentation until age of 50 or older, less severe symptoms. Cardiac troponin T mutations that have modest hypertrophy, increased risk of sudden death, and cardiac troponin I mutations have greater predisposition of apical hypertrophy. Alpha tropomyosin mutations have relatively good survival and variable degree of hypertrophy. These are the major genes gene mutations which causes hypertrophic cardiomyopathy. So other genetic and non-genetic causes are mostly the storage and glycogen storage infiltration disorders which cause hypertrophic cardiomyopathy, like Pompe disease, Danon disease. Then there are neuromuscular diseases like Friedreich's ataxia. There are mitochondrial diseases and malformation syndromes. Amyloidosis also called hypertrophic cardiomyopathy. Then left ventricular hypertrophy generally when there is due to sarcomere mutation without any extra cardiac or metabolic finding plus genetic substrate unresolved, then it is called as hypertrophic cardiomyopathy. And when there is extra cardiac metabolic findings or it is associated with or without mutant gene, then it is called syndrome with left ventricular hypertrophy. Histopathologically, there is a myocyte hypertrophy and disarray and myocardial fibrosis. This is a histopathological diagram showing walling and fibrosis, and this is a hard specimen showing left ventricular hypertrophy of both septal hypertrophy and posterior wall hypertrophy. Pathophysiology wise, we have divided into different topics like LV outflow tract obstruction, diastolic dysfunction. There is myocardial ischemia, mitral regurgitation, then arrhythmias, and end stage and bird out SCM. So LV outflow obstruction produced by systolic anterior motion of mitral valve. Acceleration for the SAM of the mitral valve is drawn towards the septum because of the lower pressure that occurs as blood is ejected at high velocity through a narrowed outflow tract. That is called as Venturi effect. Mitral valve is pulled against the septum by contraction of the papillary muscles, which occur because of the valve abnormal location and septal hypertrophy, altering the orientation of the papillary muscles. This is also called a hydrodynamic drag or the pushing force of flow. Dynamic obstruction of SCM is worsened by increase in contractility, which is caused by VBC, dobutamine, isoproterenol exercise, and decrease in afterburn volume, which is caused by Valsalva manure, standing, nitroglycerin, amyl nitrate inhalation, blood loss, dehydration. Definition of dynamic left ventricular outflow tract obstruction is based on the outflow gradient. That is, when there is basal obstruction, outflow gradient should be more than 30 mm of Hg. When it is non-obstructive at rest, the outflow gradient is less than 30, or physiologically or provoked gradient is also less than 30. In dynamic obstruction at rest, there is less than 30 mm of Hg outflow gradient, but physiologically provoked by exercise of Valsalva manure, the outflow gradient will increase, that is more than 30 mm of Hg. Dynamic LVOT obstruction, it is mostly caused by the hypercontractile states. Anomalous, it is also caused by the anomalous papillary muscle insertion. Then anteroapical infarction with hyperkinetic basal segments, elderly women with LVH sigmoid septum, and hyperdynamic ventricular function. After mitral valve repair, there can also be dynamic LVOT obstruction can occur. Diastolic dysfunction, it is caused by impaired relaxation, decreased compliance, which is caused by hypertrophy, disorganized cellular structure, replacement scarring, interstitial fibrosis, and account for symptoms of exertional dyspnea because of the increased filling pressures and which causes increase in pulmonary vessel pressure. So mainly the pathophysiology depend on the as there is stiffness of the chambers of left heart, and there is decreased relaxations. Stiffness of muscles of cardiac chambers occur due to the fibrosis, mainly the myocardial fibrosis, which causes the increase in LV filling pressures, which causes exertional dyspnea. Myocardial ischemia often occurs without atherosclerotic coronary artery disease in HCM. Postulated mechanism for myocardial ischemia is abnormally small and partially obliterated intramural coronary arteries as a result of hypertrophy, inadequate number of capillaries for the degree of LV mass, and increased myocardial oxygen consumption, so that is supply demand mismatch, increased filling pressure resulting in subendocardial ischemia. Mitral wall apparatus twice the normal size due to the elongation of both leaflets or segmental enlargement of only anterior leaflet or mid portion of posterior leaflet. Congenital anomalous anterolateral papillary muscle insertion into the anterior leaflet without interposition of chordae tendae and produce muscular mid cavity outflow tract obstruction more than SAM, more than LVOTO. Variations in leaflet length, that is posterior anterior leaflet length mismatch, restrict the ability of the posterior leaflet to follow the anterior leaflet and to co-opt effectively, resulting in MR. Severity of MR is directly proportional to LV outflow tract obstruction, results in symptoms of dyspnea and orthopnea. Arrhythmias, in arrhythmia there is PVCs, couplets, NSVT, SVT and AF. More commonly there is PVCs followed by couplets followed by NSVT followed by SVT, and last in 6th and 7th decade there is development of atrial fibrillation in SCM patients. Clinical presentation, majority patients are asymptomatic. So, and major dominant symptom is dyspnea on exertion, 90%, orthopnea, PND. Palpitations also occur in the form of AF, atrial flutter, SVT, VT, sustained and non-sustained VT. Congestive heart failure secondary to increased filling pressure, myocardial ischemia. Then sudden cardiac death, which occurs in less than 1% of patients of SCM. Angina is very second most common symptom after dyspnea, that is 70 to 80%. And followed by syncope and pre-syncope. Outflow tract obstruction worsens with increased contractility during exertional activities, resulting in decrease in cardiac output. And syncope also occurred due to secondary to arrhythmias also. Physical examination, jugular venous pulse is there. In jugular venous pulse there is prominent A wave, double carotid arterial pulse declines in mid-systole as gradient develop. Double apical impulse, forceful left atrial contraction against non-compliant ventricle produces double apical impulse, and triple apical impulse, late systolic bulge near isometric contraction. S1 is normal, S2 is normal or paradoxal split is present, S3 gallop in decompensated left ventricular, S4 is present in atrial systole against hypertrophic ventricle. When atria contracts against the hypertrophic ventricle, S4 occurs. Ejection systolic murmur between apex and left lower sternal border. Effect of selected maneuvers on ejection systolic murmur, like Valsalva. There is decreased LV cavity pre and after load, that is causes increase in gradient and murmur. Valsalva divided into 4 phases. In second and third phase there is increase in gradient, and in 4th phase there is decrease in gradient. In a standing also there is decreased LV cavity preload, which causes increase in gradient and murmur. Post BPC also there is increased contractility, which causes increase in gradient and murmur. Squatting also causes increased LV cavity, and pre and after load, that causes decrease in gradient and murmur. Isometric handbrake increases after load, causes decreased gradient and murmur. In holocystic murmur of MR is also present, which is caused by retrograde ejection of blood flow into the low pressure left atrium, base headed apex and axilla. Patient with systolic anterior motion, significant LV outflow gradients have holosystemic murmur of MR. Diastolic decrescendo murmur of AR present in 10% of patients due to systolic anterior motion, which causes LVOT. Due to systolic anterior motion. Mimicking other cardiac conditions which mimic hypertrophic cardiomyopathy are chronic hypertension, RV hypertrophy, cardiac amyloidosis, athlete's heart, valvular aortic stenosis. There is apical hypertrophy, apical cavity obliteration caused by hypereosinophilic syndrome, non-compaction. Now, what is the difference between the hypertrophic cardiomyopathy versus athlete's heart? So, unusual pattern of LVH is present in SCM, not in athlete heart. LV cavity less than 45 in SCM, while it is more than or normal in athlete's heart. LV cavity more than 55 mm is present in athlete's heart. Annular enlargement is present in SCM, not in athlete's heart. Bijare ECG patterns are present in SCM, not in athlete heart. Abnormal LV filling is present in SCM, not in athlete's heart. Female gender is SCM is more common in female gender. Then decreased thickness with deconditioning is present in athlete's heart. Family history of SCM is present in hypertrophic cardiomyopathy patients. SCM versus aortic stenosis, carotid pulse. In SCM there is spike and dome pattern, while there is parvus tardus in fixed obstruction. Murmur radiate to carotids in aortic stenosis, while with Valsalva and standing there is increase in murmur. Squatting and hand grip there is decrease in murmur. In passive glycolation there is decrease in murmur. Systolic thrill is present in fourth left intercostal space in SCM, while it is present in second right intercostal space in AS. Systolic case is absent in SCM and present in fixed obstruction, that is aortic stenosis. Diagnosis, we confirm by our diagnosis by ECG, imaging like echocardiography, cardiac MRI, other modalities, cath data, test to risk stratify patient, genetic testing and family screening. ECG abnormal in more than 90% of patients of SCM patients, and more than 75% of asymptomatic relatives have abnormal ECGs. ECG shows increased voltage consistent with LV hypertrophy, STD changes, marked TE wave inversion in the lateral precordial rubs, left atrial enlargement, deep and narrow Q waves lateral precordial leads, and diminished R waves in the lateral precordial leads. Normal ECG are present in 5% of patients with SCM, having less severe phenotype and favorable course, non-predictive of future sudden cardiac death. In echocardiography, we will see the presence of hypertrophy and its distribution. Report should include measurement of LV dimensions and wall thickness, that is septal posterior maximum, left ventricular ejection fraction, RV hypertrophy, and whether RV dynamic obstruction is present or not. LA volume, index to body surface area, LV diastolic function, comments on LV relaxation, filling pressure, pulmonary artery systolic pressure, dynamic obstruction at rest, and with Valsalva maneuver should identify the site of obstruction and the gradient. Mitral wall and papillary muscle evolution, including the direction, mechanism and severity of mitral regurgitation. If needed, TE should be performed to satisfactorily answer these questions. This is a parasternal short axis view showing the interventricular septum and posterior wall thickness of left ventricle. This is a 4-chamber view showing apical hypertrophy. This is mid cavity obstruction. LV hypertrophy, there is diffuse hypertrophy of the ventricular septum and anterolateral free wall. Basal septal hypertrophy is which is most common, and basal septal hypertrophy is present 10 to 15% of patients. Concentric hypertrophy is present 5%. Apical hypertrophy is present in less than 5%, more common in Japan. Hypertrophy of the lateral wall is present 1 to 2% of patients. This is a M mode at the level of mitral wall, showing the systolic anterior motion of the mitral wall. This is the color Doppler showing a dagger type of LVOT gradient. EF usually is normal or increased in SCM, can have small LV and end diastolic volumes and therefore reduced stroke volume despite having normal EF. Overt LV systolic dysfunction termed as the dilated progressive phase of SCM, end stage SCM or burnt out SCM is usually defined as LV EF of less than 50% occur in a minority of patients, that is 2 to 5%. Prognosis is 1 in the presence of LV systolic dysfunction. LV diastolic dysfunction, that is E is very much greater than A, which indicates a diastolic dysfunction. This is a radial stent. Radial stent is nothing but the deformation of the heart muscles from the endocardium to the epicardium, as the first graph is showing the normal radial stent, which is of 3.84, and second graph is showing reduced radial stent, which is indicative which is present in SCM patients, which indicate adverse outcome that is heart failure, and arrhythmias are more common in this patient which have reduced radial strength. This is also the same radial strength showing pictures. Now this is a transesophageal echocardiography. First is pre-myectomy. There is presence of SAM and IV septal hypertrophy is there, and after myomectomy there is no SAM or IVS thickening is reduced. Cardiac MRI. This is a useful modality in SCM patients to know about how much the fibrosis is there and whether this patient requires ICD for prevention of sudden cardiac death or not. Useful when echocardiography was questionable, particularly with apical hypertrophy. CNS loops typically show obstruction, and velocity mapping is useful in the assessment of peak velocity. SAM of the mitral valve is clearly seen on cardiac MRI. Improvement in obstruction after septal ablation or myectomy can be demonstrated, as can the location and size of the associated infarction, which are useful for planning repeated procedures. Cardiac MRI identifies abnormal patterns of strain, shear or torsion in cases of SCM, demonstrating significant dysfunction in hypertrophic areas of the ventricle. This is the cardiac MRI showing cardiac myocardial fibrosis. Cardiac MRI in this gadolinium contrast cardiac MRI differentiating SCM from other causes of cardiac hypertrophy and other types of cardiomyopathy such as amyloidosis, athlete heart and Fabry disease. Late gadolinium enhancement occurring in SCM represents myocardial fibrosis. The greater the degree of late gadolinium enhancement, the more likely that the particular SCM patient has 2 or more risk factors for sudden death. More likely the patient has or will develop progression of ventricular dilatation toward heart failure, thereby indicating a poorer prognosis. Most patients with SCM have no gadolinium enhancement. Common benign patterns in 2 strips running along the junction of the right ventricular insertion into the left ventricle. In cardiac catheterization, diagnostic cardiac catheterization is useful to determine the degree of LVOT obstruction, cardiac hemodynamics, and the diastolic characteristic of the left ventricle, LV anatomy, and coronary anatomy. Reserved for situations when invasive modalities of therapy such as pacemaker surgery are being considered. Therapeutic cardiac catheterization interventions include transcatheter septal alcohol ablation. The arterial pressure tracing found on cardiac catheterization may demonstrate a spike and dome configuration. This is a spike and dome configuration. This is a cardiac CT showing LV cavity dimensions and the septal hypertrophy and posterior wall thickness. Coming to the natural history, there are prognostic profiles which include sudden death, heart failure, end stage, atrial fibrillation, stroke, benign or stable, that is normal longevity. Burnt out SCM occurs in 3% of patients. Systolic dysfunction is systolic dysfunction is present with EF of less than 50% associated with AF. Wall thickening and cavity dilatation is present. Diffuse transmural scarring, progression to refractory heart failure or sudden death. Mortality is 10% per year, and most reliable risk marker is family history of end stage disease. Coming to the management of SCM, we have divided into different therapies like beta blockers, calcium channel blockers, then disease modifying drugs. The first is the beta blocker. Beta blocker slows the heart rate, reduces force of LV constriction, augmenting ventricular filling and relaxation, decreases myocardial oxygen consumption. Long antic preparation like propranolol, atenolol, metoprolol or nadolol are used. Blunt LV outflow gradient triggered by physiological exercise. Target resting heart rate is 60 beats per minute, may require up to 400 mg equivalent of metoprolol. Verapamil, which is a class 1 in drug, add-on therapy of beta blockers if 5 doses of beta blockers are not tolerated. First choice when beta blockers are contraindicated. Maximum doses of 280 mg per day. Avoid in NYHA class 4 dyspnea and hypotension. When used as an added therapy, to look for high-grade AV block. Diltiazem, when verapamil cannot be used, diltiazem can be used. Disopyramide, which is also used, disease modifying drug, have negative inotropic effect, decreases the gradient and improves symptoms. Concomitant beta blockade may be important to prevent rapid atrioventricular node conduction. Between 300 to 600 mg per day. The corrected QT interval must be monitored. Anticholinergic side effects in older patients can occur. Agents that modulate myocardial metabolic efficiency and the major mechanism for potentially improving energetics. Following agents can be used like paraxylene, amiodarone, trimetazidine, ranolazine, metformin. Drugs that can harm in SCM are nifedipine, nitrates, diuretic, potent vasodilator, hence avoided, can decrease the preload and afterload, preload. Digoxin, dibutamine, non-adrenaline, dopamine, positive inotropes. Management of acute hypotension in HCM. Hypotension should be avoided, but it can be because sudden cardiac death occur when hypotension is not corrected. So whenever there is acute hypotension in SCM, it should be corrected by IV fluids, phenylephrine, IV beta blockers. Management of SCM with systolic dysfunction, we should add ACE, S inhibitors, ARBs, diuretics, standard heart failure treatment, discontinue verapamil, diltiazem and disoparamil when systolic dysfunction occurs in SCM patients. Management of AF, that is hemodynamically stable. If hemodynamically unstable, then DC version should be tried. If there is angina, pulmonary edema, AF, then beta blocker should be added. Hemodynamically stable, then oral anticoagulation. 3 weeks oral anticoagulation should be given, followed by DC version. Rate control with oral beta blockers and calcium channel can also be done. Rhythm control with amiodarone can also be done. Flicamide and propafenone should be avoided as they may prolong QRS duration and the QT interval. AV nodal ablation followed by triple DR, VVIR or CRT in drug refractory cases. Radio frequency ablation can also be done in drug refractory cases of AF in SCM. So are there any alternative or additional explanation for symptoms of SCM like obesity, respiratory disease, coronary artery disease, anemia, thyroid disease, arrhythmia, drug side effects, systemic diseases, RVOT obstruction? Then this should be treated. What is the mechanism of action should be identified, that is SAM related, mid cavity obstruction, subaortic membrane, aortic stenosis, anomalous papillary muscle insertion, accessory mitral valve. Then assess mitral valve anatomy and function, that is mitral prolapse or other intrinsic abnormality. Assess distribution and severity of hypertrophy, that is maximum in anterior septal thickness 17 mm. If it is more than that, then we have to look for the alcohol septal ablation or myomectomy. These are so septal myectomic procedure is also known as Moro procedure, in which there is septal reduction is done, which reduces the LVOT outflow tract obstruction. It is mostly considered in patients with drug refractory heart failure symptoms, NYHA class 3 or 4 or exertional syncope, LV outflow obstruction with gradient of more than 50 mmHg, better surgical candidates such as younger age, greater septal thickness more than 30 mm, concomitant cardiac diseases like valvular or coronary artery disease. Septal myectomy has complications also, that is perioperative mortality VSD 3%, CHB and PPI 5%, cerebrovascular accident 1 to 2%, LVVV 40% of cases there occurs LVVV. Then another septal reduction therapy is alcohol induced septal, is non-invasive. That in this alcohol septal ablation has three triphasic response, in which the first there is 40 hours decrease in LVOT gradient, then after that there is increase in LVOT gradient up to 1 month, and after 1 month there is after that there is further decline in the LVOT gradient. Other than alcohol, we can use polyvinyl alcohol foam particles, microspheres, absorbent gelatin sponges, septal coils. So in septal alcohol ablation versus myomectomy for hypertrophic cardiomyopathy, septal ablation does seem to show promise in treatment of SCM owing to similar mortality rates as well as functional status compared with septal myomectomy. However, the caveat is increased conduction abnormalities and higher post-intervention LVOT outflow tract gradient. The choice of treatment strategy should be made after a thorough discussion of the procedure with the individual patients. Dual chamber pacing is done in patients when there is proposed benefit, that is pacing the RV apex will decrease the outflow tract gradient by decreasing projection of basal septum into LVOTO. Several randomized controlled trials have found that the improvement in subjective measures provided by dual chamber pacing is likely to have placebo effect. Other treatment like EP, CRT, cardiac transplantation, and ventricular assist devices should be used. Efficacy of therapeutic strategies like dual chamber pacing and septal myectomy, septal ablation. The effectiveness is more in septal myectomy, that is surgical procedure, but if the patient is not fit for surgery, we can try septal ablation, which is more effective than dual chamber pacing, which have effectiveness only 10 to 40% of. This is the European Society of Cardiology guideline for the SCM risk, that is sudden cardiac death risk calculator. In this, we look for the age, maximal LV wall thickness, left atrial size, maximum LVOT gradient. Then there is any family history of sudden cardiac death, non-sustained VT, unexplained syncope. Where in this various there is score is given, after which we can calculate a trivial score, and then the ICD is recommended or not, we can decide after that. So if the patient has prior cardiac arrest or sustained VT, yes, ICD is very recommended. If no, then we look for the family history of sudden cardiac death in first degree relatives, or LV wall thickness of more than 30 mm, or recent unexplained syncope. If these are present, we can consider it for the ICD. If this history is also not present, then we can look for the non-sustained VT or abnormal BP response to exercise. If yes, then ICD is recommended in this patient. If not, then ICD is not recommended. This is algorithm positive family history of sudden cardiac death, that is cases with sudden cardiac death less than 45 years, recurrent syncope more than 2 incidents, LVH more than 30 mm of Hg, abnormal blood pressure response during exercise, that is increasing less than 20 mm of, that is increase in BP is less than 20 mm of Hg, or fall more than 20 mm after transient exercise, non-sustained VT in Holter ECGs. Second degree risk factors like atrial fibrillation, atrial flutter, LA dilatation, high LVOT gradient at rest, evidence of myocardial ischemia during exercise, early manifestation of SCM, that is less than 30 years of age, myocardial bridging near the LAD, marked fibrosis, cardiac MRI, then these are the risk factors. After, if present in the patients, we can consider the patient for the ICD. This is overall SCM population in which there is heart failure symptoms. First we try with drugs. If drug refractory symptoms are there, we classify the patient according to obstructive or non-obstructive. If obstructive SCM is there, we can proceed with the septal surgery, septal myectomy. If a patient is not fit for surgery, then alcohol septalation or triple DR pacing can be tried. And if there is non-obstructive SCM, then end-stage disease is there, we can treat with it afterload reduction like diuretics, digoxin, beta blockers, spironolactone, or if not refractory to these drugs also, we can plan patient for the heart transplant. Certain patient with SCM with pregnancy, high risk if LVOT gradient is more than 50 mmHg, class 3 for those with class 3 and 4 systolic dysfunction, no added risk for patients with controlled symptoms. Continue drugs in pregnancy, watch for fetal bradycardia and growth abnormalities in fetus, guard against post-delivery volume loss. Prevention of hypotension is of utmost importance in patients with SCM who is undergoing delivery. Physical activities, we have to take a low intensity aerobic exercise, avoid dehydration, avoid heavy meals. Risk of syncope is high in high intensity sports. Unpredictability of sudden cardiac death, another reason to avoid high intensity sports. So we have a risk score of calculating that sudden cardiac death can occur or not, and ICD is recommended not, but we cannot predict in every SCM patient that sudden cardiac death occur or not. So high intensity sports is avoided in SCM patients. What to expect in future? Well, alcohol septal ablation will be overtaking surgery. Alternatives to alcohol can an inclusion of cardiac MRI in diagnosis and risk stratification, and preclinical diagnosis with echo. Another drug which is used in SCM is mavacamten, that is cardiac myosin inhibitor, which reduces the actin myosin cross bridges which reduces contractility and help in reducing LVOT gradient, and also reduces the intraventricular septal thickness. It is given in 5 mg OD doses, and therapy is up to 8 weeks. After every 2 weeks dose escalation should be there depending upon the LVOT gradient and septal thickness. It is currently available in 5 countries and not much used in India due to the cost factor. So in future we can be seen using mavacamten in patients with SCM. Thank you.